Right, so we'll get started. So, hello everyone, and welcome to the 20th monthly Plain Film NCT webinar series. My name's Becky, and I'm an account executive at Collective Minds. So, I'll just be co-hosting and doing a bit of admin on tonight's webinar. And today we've got consultant radiologist Dr. Lasker with us. So he'll be discussing cases and showing them on Collective Minds. So in a moment, I'll just post a link into the chat. So this will allow you to log into Collective Minds and then you can review the cases alongside Dr. Lasker. If you've got any questions during the webinar, then please pop them into the chat box. And if you've got any issues accessing the cases, you can also use the chat or just drop an email to support@cmrad.com and someone will be in touch. So I'll now hand you over to Dr. Lasker and you should have access to the link in the chat.
So hey everyone, I hope everyone is well. Thank you so much for signing up. I think we've actually had a bit of a record sign up this month, which is absolutely phenomenal to me. Absolutely amazing that we managed to have that many people signing up to the webinar, and hopefully I still continue to give value. I was not available in December. Unfortunately, my daughter wasn't very well. So I think I'm going to almost selfishly ask you guys, if possible, could you put a spare a thought or a prayer towards her because she's still a bit sick, but getting better slowly. So I'd really appreciate that. What I'm going to do is I'm going to keep the chat open. As usual, we were able to kind of talk to each other during this thing, and if I get things wrong, I get things wrong. We can talk to each other, and I've learned a lot from doing these for people as well, where I've kind of misinterpreted something and someone's pointed out. So there's no kind of ego, anything like that here. I'm not trying to pretend to be like the go-to person. I like to teach. I like to go through cases, and if you're a bit of a radiology nerd like me, then this is going to be great. So you hopefully got the link. If you do have any problems with accessing the link, then do let us know in the chat, and we'll try and sort that out. We've got, plain film webinar, monthly webinar number 20. So this has been going on for a while. So this is really, really great. So let's go through case number 20. And the way it works, I'll go through things and there'll be varying difficulty of cases that we do. Yes, of course, some things will be very, very straightforward because some people are very good and they've done a lot of radiology. And there'll be some cases that people may struggle with a bit, and that's fine too. So, well, let's have a look at this one. And obviously, if you think you know what it is, then go for it. But this person's got a significant amount of pain in their knee. And the problem is, like, you've got this X-ray, and first off, you've got to try and think about, okay, first, what can we see? What's going on here? And we can see that there is some sort of calcification here. Can you see that? This kind of linear calcification. So when you get this linear calcification like this, you got to start thinking, okay, so there must be kind of an older person, right? There must have got some vascular calcification. So that's kind of a bit of a clue as to what's happening here. And then what I always do, I always kind of go around every single contour like this and draw all the way around, all the way around, all the way around like so, and just make sure that I can draw it around nicely to look for whether there's any sort of fracture or anything else like that. And again, with the fibula as well, you go all the way around, all the way around, all the way around, all the way around like so, all the way down like so, all the way down like so. That looks okay. When you get to this area here, you can start to see that actually there's a bit of a punched out area over here. The intercondylar looks a little bit large, actually. It looks kind of big. It doesn't feel like it should be that size. And coming up to the more peripheral aspect here, there's another sort of punched out area over there. And coming to this area here, which is the medial aspect, there's another punched out area. Can you see that over there? So with regards to the rest of the knee, I don't think I can convincingly say there's any sort of soft tissue lesion. I can't see anything sort of going into there. I can't see any soft tissue lesions within there and no abnormal calcifications. Coming up to that suprapatellar region, you can actually see that there is a little bit of fluid located there as well. So there is a bit of a suprapatellar joint effusion. So you've got an older person, you've got some vascular calcifications, and you've got a suprapatellar fusion. Now, fair enough, someone's gone for where this could be a tibial fracture. Now, the reason why someone may think it's a tibial fracture is because, yeah, you do have these very abnormal areas located here, 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 and here. Now, you can get very complex tibial fractures where, yeah, there could be comminuted, which is basically a fancy word for um, a complex tibial fractures, but you don't really see any linear abnormalities going anywhere else. These are very well defined and very, very well punched out. If it was a tibial fracture as well, you probably would have a lipohemarthrosis where there'd be like a flat line over here, right? Because the blood and the fat from the fracture would kind of settle in a particular area. But this, you don't really have that here at all. You just got the supratellar effusion, and you've got these sort of punched out areas over here. And this widening of the intercondylar notch is also something to be taken into consideration. Now, if I said there was no trauma, you've got to start going down the lines of, okay, so you've got no trauma in an older patient. What could this be? So then you've got to start thinking about, is this inflammatory? Is this some sort of rheumatoid arthritis? And I think we've got a poll. So hopefully Becky can give that poll out. So that poll's coming out. And if you could just tell me what you think it is. And in the meantime, I will start to explain. So, like I said, I don't think we can go down the idea of this being a fracture because we can't really see much in the way of lipohemarthrosis. You don't see any linear abnormalities anywhere. Osteoarthritis is not a bad shout because, yeah, they are older. But one of the ways I remember osteoarthritis is, you use the word loss, Loss. Yeah. So L is for loss of joint space, O is for osteophytosis, S is for subarticular sclerosis, and the other S is for subarticular cystic change. So in this area, you don't really see loss of joint space. So if there's no loss of joint space, you can't really go down the idea of this being osteoarthritis. And you do have a little bit of a loss of joint space on the medial aspect, but not really enough to tell you, like, give you these very abnormal looking areas, right? So rheumatoid arthritis, potentially, but one thing that's taken away from rheumatoid arthritis is the fact that they've got what is known as a periarticular erosive change. And looks like, yeah, so 58 people, 58% went for gout, and that's exactly what this is. And so I'm going to share those results so everyone can see. Scleroderma, you'd think about, multiple punctate calcifications, chondrocalcinosis, that kind of thing. Doesn't usually hit the big joints. But gout, it does. It hits the big joints, and you get these periarticular calcifications, right? Periarticular erosive changes, and you can get sort of widening of the intercondylar notch. So obviously, right now, anyway, we're all radiologists, aren't we? So do we just say that, or we need to say something else, don't we? We can't just stop there. So we've got to say to them, okay, so we're thinking this could be gout, and therefore, if we think it could be gout, we have to think about doing a aspiration and sending it off for urate and also looking for crystal arthropathy within there. So gout is essentially crystal arthropathy, and it could be this patient has multiple attendances. So this could be one of many. So having a look at previous X-rays is always very useful because it may not have changed all that much, or maybe some of these erosive changes were there from previously, and we're just seeing new ones that have turned up, and that's why they've come in with pain. But also other big joints can be affected. You can have the ankle joint, the big toe, which is the classic, isn't it? The big toe is the classic one that people would say is being affected. Right. So what we'll do now is go to the next case. Hang on. My screen. So yeah, well, let's go to the next case. So hopefully there's no questions about that one, and go to the next case. So case number 2. So this person came in with abdominal pain, and hopefully it'll download soon. If you guys get it before me, then please feel free to shout out, or got looks like an adult patient. You can tell that because if you look at the iliac blades, they look like they're fused. There's no growth plates there whatsoever. And the actual bones, you can see there's a spine, kind of got this kind of lateral osteophytosis, a bit of osteophytosis there. So a bit of osteophytosis there that can only really happen in older patients. And then you can see multiple loops of dilated bowel, right? That's what it looks like. So if I could try and draw some here, so let's do that. So draw around there and there. So this looks like very dilated bowel. Then you've got to look for like whether it's haustra or whether these are, it's not a bad shout actually. Someone said, could this be about a volvulus? So it's not a bad shout. I think it's a good idea. But when we are looking for a volvulus, we'll be looking for like a dilated viscus coming from the pelvis, either going towards the right or either going towards the left. If it's going towards the left and looks like a coffee bean, then we're thinking along the lines of a sigmoid volvulus. If it's the other way, if we're going to the right, then you think about cecal volvulus. So actually, I would probably not go with the cecal volvulus. So toxic megacolon is not a bad shout as well because yeah, it does look a little bit featureless. And then these look like haustra. They're not valvular conventives, right? Sigmoid malignancy or obstruction. It potentially could be. It's not a bad shout either, but I don't think we can really go down that road because it is a plain film at midday. And if you were looking at obstruction, I guess it'd be fairly low down, like a rectal obstruction. But actually, I think someone has written double wall sign, and what I assume they mean by that is that normally when you see bow wall, so I'm going to just draw the bow wall here. So you see that bow wall, you should see one side, but not really the other side. And actually, when you look here, you can see bow wall here, but you can also see this side and this side. And so the interface between air and bow wall should only really exist between within the bow, because within the bow you do have air. But outside the bow, you shouldn't have air. And if you have that interface, if you can suddenly see quite a nice, well-defined line like this, in so many areas, like here, here, over here as well, and over here, then you have to go down the idea that this person's got a bowel perforation. And that's exactly what this patient had. It could be quite a serious condition, and they're an older patient. And unfortunately, I think this patient passed away before they were able to get any further imaging. But exactly right. So it's going to be perforation because of that interface. So you've got to remember that when you're looking at X-rays and CTs, it's all about density. And normally, when you see bowel on an X-ray, because outside the bowel is going to be fat, maybe you've got some fluid, you won't really see like much of the outside wall beyond the outside wall. It will kind of be kind of a hazy, kind of whitish thing. But in this situation, you can see it so well that this has to be air on both sides, giving you that quite nice, or not so nice for the patient, but the interface of what essentially is a perforation. And does anyone know what that's called? I think they call it Wriggler's sign, don't they? Wriggler's sign. So anyway, so let's go on to the next case. So this is case number 3. And so for those that don't know Collective Minds, I use Collective Minds a lot actually for a lot of my teaching and all the courses that I run. I run courses on radiology seminars. So if you are interested in learning from us on that platform, then please feel free to. We've actually partnered with Collective Minds as well. So they do the kind of the background of the images that you get access to, and then we do the teaching on the side of it as well. And what you can see is that you can download the images. The images don't take that long to download, and there's quite a lot of us right now on this platform, and it's still coming in quite nicely. And then you can just scroll through just like any other PAX viewer that you guys may be aware of. So let's have a look at this one. So what I usually do, and what I'd always recommend for people, is that you do one scroll through. Before you do anything else, just do one scroll through of any CT, all the way down, and go right to the very bottom, and then come all the way back up, and just sort of take in what's going on. And then again, with this platform, you can actually use windowing. So if you press, I think it's going to be 4, you can go to long windows. So that's really good as well. So you get all the windows that you need. So when you see these areas over here, can you see like around here, the lungs don't look very well defined. They kind of look kind of wavy. They almost look like little seagulls, right? So I'll try and draw a seagull for you. So they'll be like a little seagull. If they look like little seagulls, then they've had a lot of breathing artifact that's degrading some of these images. Scrolling further down, you can actually see here, there is this sort of kind of haziness in the middle of all those seagulls. So there's a little bit of breathing artifact, but there's haziness here as well. But that would be more in keeping with consolidation. So there is some consolidation as you come further down. And this is more well defined, and you can't see any air bronchograms. For those that don't know what air bronchograms are, in consolidation, you'll have little kind of airways that are not, which are not kind of blocked up by pus or fluid or whatever it is. That's consolidation. But here, that's not consolidation. It's very, very well defined. Looks almost crescenteric-like, and so therefore that would be a pleural effusion. Coming further down, you can start to see more sort of confluent areas where there's less of those kind of like tiny little airways within there. Looks more confluent and more solid. Further down and further down, this feels like almost crescenteric here. So it's probably a small pleural effusion there. And coming further down, it just gets worse and worse for this patient, unfortunately. It looks like they've got a combination of quite significant consolidation. So someone's done really well there, and also start to wonder, well, okay, is there something else going on? Because, okay, you do have extensive consolidation, but some of these don't really look like consolidation or like focal consolidation, because normally with consolidation, you get sort of kind of wavy, irregular shaped things, but some of these actually look a little bit circular. Right. And especially because at the lower lobes, you've got to start wondering, okay, we've got multiple lower lobe lesions, right? And they look very circular, very, very spherical. So that one there, that one there. And with a malignancy anyway, you'd be more likely to get multiple comorbid metastases in the lower lobes, and that's because of the way the blood flow is. Because if someone's standing around, in theory, the infected blood would be in the lower areas of the lungs, and that's where you get more of your malignancies. You get multiple comorbid metastases in the lower lobes. So that's something that we are worried about. Now, septic emboli could happen. Usually, you'd be looking at sort of cavities. I don't think we see much in the way of cavities, and they wouldn't be so predominantly in the lower lobes. They'd be generally quite well defined, and they'd be all over the place. And also, when I was just going to mention something quickly, is that the idea of the blood flow kind of going downwards is why you get some apical scarring usually, which is kind of normal because over time the APCs don't get as much blood and stuff as they usually would, and they start to kind of fibrose a bit. You do have this calcified granuloma here though, which is one thing. So the other thing you need to do with any of these cases is, so at the moment we're thinking, okay, it could be, yeah, multifocal pneumonitis. Yeah, it could be. It could be a background of cardiac failure as well because these bilateral pleural effusions, right? Then you also got to try and see whether you can find any lymph nodes. And it can be difficult in these non-enhanced studies. And this is a non-enhanced study because if you look at the aorta, that looks very, very similar in terms of its density towards the pleural effusion and everything else. So we can't really go with the idea that this is not a contrast enhanced study. But can you see here this thing over here? So I'm going to try and point it out again. That little thing there, if you kind of come up, it disappears, and we come down and up, it disappears and disappears, right? So that actually looks different, separate from the vessel. So there does look like there is an enlarged lymph node around there. Hyalo-wise, it can be a bit more difficult because again, it's a non-contrast study. Someone has said, could it be lymphangitis? Yeah, you can have lymphangitis, but generally speaking, when you're looking at the lungs, they look like nets, like a proper net. So with lymphangitis, you're saying there's too much lymph, and you normally get sort of thickened thickened interlobular septi. But here, we don't have any thickened interlobular septi. So we're kind of going between, okay, we're kind of gearing towards this probably going to be infection, maybe background of cardiac failure, right? Because you've got bilateral pleural effusions. Also, they could be parapneumonic effusions as well, because someone could have effusions as a result of infection in the first place. But then also, we're all radiologists right now anyway. We have to look at everything else. So supraclavicular wise, yeah, the thyroid may be slightly enlarged, but not much else is going on. The axilla, they don't look like they have anything else going on either. There's no enlarged lymph nodes. So you'd be looking for lymph nodes in the armpits over here. So, and yeah, so someone said could be metastatic lobe. Yes, it could be, but I don't think we can convincingly say that we've got a focal primary because the primary would usually be the big one. Very, very obvious, and then you'd have all these small ones. So we've got to still think about what else it could be. So then we have a look at the liver, and it's a non-contrast study. I get it. Like it's not going to be entirely easy to try and figure out what's going on with regards to the kidney, the liver. But then the liver looks okay. The pancreas, sometimes you get pancreatic malignancies, but that looks kind of fatty and kind of slightly nodular, but that looks all right. No focal lesions. The spleen looks okay. And the adrenals, which are here and here, they look okay as well. But yeah, someone's hit the nail on the head. So if you come further, oh, someone said, is it a pericardial effusion? It's come up here. So yeah, you do have a little bit of fluid. It's not something I'd be too worried about. It's very, very thin, but not enough to be thinking they've got some sort of pleurisy or anything like that. But someone has managed to find something quite abnormal. Can you see that? So what about the hepatic flexure? So let's go. Hepatic flexure, that's going to be here, isn't it? So you come across this way, and actually that looks okay. And you go across, it looks like it's going this way, don't have the entire thing. And then we're all the way to the splenic flexure. But this is what's abnormal. Can you see this? Yeah, this exactly. People have found it now. So I'm going to draw that out. This here is not normal. This is a very large lesion emerging from the anterior aspect of the mid right kidney. Looks very, very ill-defined, maybe a tiny calcification or something within there because it's a non-contrast study and you've got some hyperdense areas. But there's also some fat stranding located within this region, right? So now you're thinking, okay, this looks like a primary right cell, yeah, an RCC, right? And then you've got to be a bit more careful now because you've got multiple, potentially, it could be a couple of things, right? You could have a multiple metastases on a background, no, you could have pulmonary infection, so you could have consolidation and infection on a background of metastatic disease. That's entirely possible. But because we've seen these multiple, because we've seen that primary lesion located within the kidney, that's when you've got to start worrying that there is, these are going to be potentially multiple metastases. And I'm going to show you something else about the platform, which I think is really impressive, is that you can actually do all the stuff that you normally do, do coronal, do axials, all from the same CT that you'd have in your work computers, which is why it's been so good for us to be able to teach people and not just show people the answers, but how to get to the answers too. And so now here we've got to, because we know this patient's got malignancy, we've got to really try and see if there's any sort of destructive bone lesion. And you come to this area over here. What's people saying? Right renal vein distended. Yeah, so yeah, I was going to go on to that. That's a good point. So some people may worry that this could be, this over here could be a focal metastatic lesion. But when you look at it, they look kind of linear and very straw-like. And so when you've got straw-like fatty areas, it's probably going to be a hemangioma, exactly right. And then just got to still look through it. You've got to really look. So again, that could be hemangioma. It looks very linear and hypodense. And I haven't seen any sort of abnormal abnormalities with regards to the rest of the bones. So someone said that which is actually a very good point. I have to say though, this is a non-contrast study. So unless it's blindingly obvious, I wouldn't really go with it. So one thing someone said is that the renal vein looks slightly distended. And that's actually one of the things that can happen with an RCC, that you get extension of the renal cell cancer into the renal vein. So that's entirely possible, but I would be hesitant. I may mention it, but then at the end of the day, there's no point in trying to be too much of a hero. You see the RCC, you're worried about pulmonary metastases, and you're going to end up getting a contrast and unstudied for full staging, right? You're going to do the abdo-pelvis and CT head as well, just to make sure there's no intracranial metastases. Now, the reason why I thought this was quite good is that if you weren't going all the way through, like if you just sort of scroll through, you think, okay, cool, looks like infection, leave it at that, then you're going to leave this person with infection. But that's what I noticed, that like the last cut, the last slice could slice your career essentially, because that literally is like the last what 4 or 5 slices where there's this clearly abnormal lesion which completely changes the trajectory of the entire clinical picture. So this person could go home with antibiotics or get what they actually need, which is probably going to be full staging scan, potentially biopsy, or excision and referral to urology and all that kind of thing. And so you can see why it's very, very important that in radiology anyway, I guess anyone who is doing any sort of imaging, you really have to look at every little thing, because this person actually, from what I remember, came in with um, it was, I mean, it was a non-contrast study because they thought it was non-healing infection or something. So that's why they did this. And it turned out it was actually the RCC that's probably causing most of the problems. Right. So yeah, well done. A lot of people came up with some really interesting stuff there. TB infection. Yeah, I would probably not go with TB infection on this one because it's such an abnormal looking lesion located within that kidney. They were an older person as well. I don't think they fit the demographic for TB. I mean, it could be. Of course, you never say never, because I think TB is one of those things that like could literally do anything. And I think sarcoid as well. Sarcoid can just look really weird sometimes. So you can't 100% say no way. But I think on balance, you're probably going to have to go with it being, yeah, it's probably less likely. So this one, I think we've got another poll, so hopefully Becky can put that up. And it's just going to be a question as to what it kind of is going to be very related to what you actually think the problem is on this one. So I'm going to work through it and then we'll try and figure out what it is together. So we have a non-contrast CT. I can see it's a non-contrast CT because the aorta doesn't have any contrast within it, and it looks very much the same density as everything else around it. And if it was an aortic image, aortic phase image, then you'd see a very high density aorta compared to the bone. But you can't see that, so that's a non-contrast study, and I think therefore this is probably going to be for a CTKB. So let's have a look at these kidneys, see what's going on. So you've got kidney there, I mean, you've got kidney there and kidney there, and you've got these sort of spherical lesions located there. These are most likely to be multiple renal cysts, and there's multiple of these renal cysts on both sides. This one maybe look a little bit dense, so might suggest if they've not had one before, do an ultrasound to have a closer look. Now, when you look at the renal hilum, which are these areas over here and here, they look very, very fatty. And they wouldn't look fatty if they were inflamed or they were blocked, because then the ureter would take up most of that space. But the ureters don't look blocked at all. And then let's go stick on the right side and try and see if we can find the ureter. So that's the ureter, I think, there. Let's try and follow it down. And this does take a bit of practice. And over time, what you notice is that your eyes just sort of almost kind of assume you know where it's going to go. Like, I know that's probably going to be somewhere here. And if you ever get lost, my big recommendation is go from the bottom. So it's going to be the vesicular ureter junction. You're coming up, you can see that ureter that way. You can see that ureter coming around there, coming around there, coming around there. And it all looks very, very thin. I haven't seen any calculi whatsoever. So then we go to this next one and see this ureter go all the way down, all the way down, all the way down, all the way down. Okay, looks like people knows what this is, so I'll go quickly. And you can see the vesicular ureteric junction looks okay. Now, one last thing I'd say is always go a bit further down just to be sure that there's no calculus sitting within the prostatic urethra, within the bulbous urethra. That does happen where the calculus is actually still on its way out. We've just managed to catch it. I've seen a few cases like that. But anyway, I don't think this could be a kidney problem. And then let's have a look at the gallbladder. Gallbladder's here. It doesn't look particularly bad. It looks like it's pretty thin-walled. And now we've got to look at the pancreas. And so the pancreas is over here. And if you look at the pancreas over this area over here, it looks okay. But around this middle area, can you see that? It starts to look a little bit, it's a very, very slightly fat It looks very slightly fat, and around it, there's a lot of fat stranding. Like if you look at the fat over here, so let's do that. Fat over there compared to the fat over there, right? So that fat looks slightly fat stranded, and you come further down, that does look like there's a little bit of fluid that's emanating from that going downwards. So on balance, when you look at that, you think to yourself, okay, the kidneys look okay. They've got this abdominal pain. They've probably got examined. Someone thought it's right or left-sided. But actually what's going on is most likely, and actually when you zoom in a bit so we can all show each other. So let's go to zoom. Yeah, it's all around this pancreas, like there. So this is going to be pancreatitis. And so the question I put to you guys is actually a question based on what you think the diagnosis is. And so, oh yeah, so let's do that. Let's go reset all. I said is a bowel ischemia. So it's probably quite important that we do look at the bowel since I've brought that up. So bowel ischemia, let's have a look at the bowel. So you always go from the bottom, go all the way along like this, sigmoid colon, all the way along like so, all the way along like so. And then if you ever get lost, my constants are always going to be the descending colon and the ascending colon. The sigmoid colon can move around a lot, and the transverse colon can move around a lot, but these two are normally generally quite stable. So if you ever unsure where to go, start from the descending or the ascending and work your way back again. You can see the bowel going this way, going this way, going this way, and then down this way, and it all looks okay. Can we find the appendix? Maybe somewhere there. Maybe. It doesn't look inflamed though. It doesn't look like there's anything going on there. So there's no bowel perforation. We've ruled out appendicitis. There's no ischemia from what we can see. So therefore, we're saying this is a pancreatitis. One of the complications of pancreatitis is splenic vein thrombosis, because that's a splenic vein over here. And because it's so close to the pancreatitis or to the action, that can result in sort of a prothrombotic situation where you end up getting a thrombosis within that region. And over time, you can actually get splenic artery aneurysms as well. You can get collections over time. So those are all things to do with pancreatitis that I would, in my report, I always try and like write that because someone said uncomplicated oh, did you say diverticulosis? Oh yeah, diverticulosis. Yeah, fine. That can be quite common. You can get diverticulosis. Yeah, that's like these tiny little outpouchings in the bowel, but they don't look inflamed. Interestingly, they do actually have these kind of inguinal hernias, which can contain a little bit of fat. I think mostly on the left side. But otherwise, yeah. In my conclusion, I would say non-contrast study, limited non-contrast study, no kidney abnormalities, but there is some fat stranding around the spleen, the pancreas. This would be key with pancreatitis, correlate with the amylase. No secondary complication has been identified on the study. If there's any clear concern, I would recommend doing a contrast enhanced study because on a non-contrast study, it's going to be very, very difficult to be able to see or say whether this person's got a splenic vein thrombosis or anything else going on anywhere else. But anyway, I thought that was quite an interesting case. Let's end the poll and then we can share the poll. I think we're sharing. And you can see that actually most people, yeah, went for it. They kind of got it straight away that this is underlying pancreatitis. Right, so let's have a look at the first CT head of the evening. Let's close that. Okay, not sure what's going on there. Let's just try and open it again. Sometimes opening a new tab might work, and if that doesn't work, I'll open that one, a new tab. Maybe that will help. Oops, that didn't work either. Okay, hang on. This happened to me once before, actually. Can anyone tell me if this opening on their side? When you click on case number 5. Nope, it's not opening either. That's very annoying. Becky, are you there?
I am, yeah.
Some
I'm just trying to open it as well, and it seems to be taking a while. I'm just going to try another case.
Okay, we're going to try. Okay, yeah, it's open for me now. So maybe it'll just take a while. Apologies, it hasn't opened for you. Maybe just leave it while I go through it and then it will come up for you in a bit. So let's go through this one. So this is a CT head that comes in and they look like could be a younger patient. And you can tell because there's not much in the way of these, the gyral fold. As people get older, they start to kind of, I guess the head just dries up a bit, right? And actually their brain looks kind of quite full. It looks actually pretty good. Scrolling through. If anyone sees any abnormalities, give us a shout. If not, no worries. Let's have a look. Again, let's go from the very, very top. So what I always do, I always go from the very, very top and also have a look at these sort of the sulci here and just make sure they look very symmetrical. And actually they look pretty symmetrical coming down this way. Everything looks okay so far. Coming further down, coming further down. I haven't seen anything, any big bleeds or anything like that. The lateral ventricles look okay. They look very kind of slit-like, but it's probably because they're quite small, they're quite young, so I'm not particularly worried. And yeah, and then you come down to the kind of foramen magnum, make sure there's no crowding, no posterior fossa mass either. So this person was a trauma. And so when you have trauma, what happens is like these are acceleration deceleration injuries, right? So you're going to go forwards and they're going to hit the front of the head. And then that acceleration deceleration injury will normally end up having injuries in the frontal lobes and in the temporal lobes. So let's have a look at that frontal lobe. And now, exactly there. Can you see that there? Let's zoom in a bit for anyone that can't see. Just there, coming there, you can see slight hyperdensity around there and a hyperdensity within the center. So that would be in keeping with multiple contusions. So these are contusion bleeds. They don't look like subdural hematomas and they don't look like subarachnoid bleeds either, because subarachnoid bleeds would be very, very linear. So therefore, we've got some small contusions in the frontal lobes. It looks like they're mostly on the right frontal lobe from what I can see. The next place you want to look is going to be the temporal lobe, because that's another area where you can get significant impaction. But I don't think we see any sort of contusions, do we? Actually, look there. There's a bit of hyperdensity located there. Coming further up, you might have to be a bit worried. There could be a bit of a small bleed there. But everything else looks okay. So we could say that, okay, well, nothing else is going on. But now what we need to do is try and see if we can window it a bit. So now when I windowed it to about this much, can everyone see that there's actually more to this? Can you see that there? Coming down that way. Yeah, so there's really, really small subdural hematoma just there. Very, very thin. Can you see that? Very, very like you could potentially miss it, because if we go back to reset and reset all, because the bone is so bright, you could just think, oh, it's just the bone. But actually, when you come to here, you can see there's a separation between the bone. And this is where I think is quite useful to look at the CSS bases, right? You remember how I was saying try and look for where there's symmetrical. So it's symmetrical up here, but when you come up to around this area here, so let's come down to this region, you can see that it doesn't look quite symmetrical. There's a hyperdensity that's located there. So that's therefore you got the contusions located within the frontal lobe, and you've got a small subdural hematoma located within the right parietal region as well. And we're not completed with our examination. We've also got to make sure there's no fractures anywhere. So go to bone window. Actually, I'm going to show you guys a little trick. Hopefully it'll work on this platform. But a way to look for fractures, and I don't know why people don't do this, but I've genuinely found loads and loads of fractures doing this particular thing. So I don't know if anyone's seen it, but what we'll do, if you go to NPR, go missed oblique, do that. And then if we go to here, it says MIP, and then what you do, you increase the MIP to, let's say, 50, and then you window. Just so you kind of, it looks like more of a skull. Let's try and window a bit more. And then you kind of look at it again. And this is what I genuinely do in my practice. I would literally look at this in this kind of view just to make sure there's nothing else going on, scrolling through, scrolling through, scrolling through. And can you see that? That doesn't look quite right. So then you got to kind of manipulate it a bit. So I will show you. So this is suture. I'm going to zoom in a bit. So this is suture, this line here. Nice wavy line, because you've grown up with that, right? You've grown up with that. So there's been part of you forever. This is not a suture. It's not wavy. It's very, very linear. It goes all the way down like so. Therefore, this is a fracture. And I think doing this method, I picked up loads of like subtle. I don't think this is that subtle, but doing this method, I have picked up loads of subtle fractures. And now when we go to bone windows, let's go back and see. Look, you can see just there. There's a fracture there. It's going all the way along, all the way along, all the way along. So at first glance, you may think that, oh, it's not a fracture, it's just a suture. But actually, what's happened is that we thought the impaction was probably somewhere around the frontal lobe, because, acceleration, deceleration. But if you've got a fracture in the occipital, you probably what's happened is that you've got a injury in the posterior aspect, and then you've got a contra injury. So contra injury is where you've got an injury on the opposite side. Now, the only thing I'd say is that when you're looking for contra injuries, don't just be like, okay, they've got hit on the back of the head, so therefore it must be the front of the head. You've got to remember that these are 2D images of 3D structures. So it could be diagonally across, diagonally that way, diagonally that way. So you just got to make sure you've had a good look around the opposite area, generally speaking, to look for whether there's any other fractures anywhere else. But So in this one, I think on initial inspection, you may be forgiven to think, oh, you know what, it's pretty normal. I'm just going to scroll through. There's nothing wrong. But once you realize the trauma, go for the frontal lobes, the temporal lobes, do window, look for any potential small subdural hematomas. Try that MIP thing. I genuinely think that's a bit of a game changer, and I've spotted lots of small fractures doing that. I'd highly recommend it. Facial bones, all that kind of stuff from doing that. So try that. And you know what? Tweet me, let me know what you think. Right, so let's have a look at this next case. So this is a, well, it looks like facial bones. No, it's a mandible maybe. So let's just wait for this to come through. So I think I'm coming down with something. Feeling a bit shivery today. Maybe it's just cold, I don't know. I've heard Sweden's very cold at the moment. My cousin who's in Sweden keeps telling me that he walked out his house and there was his hair froze, which I didn't know could happen, but apparently it can. Right, so let's have a look. So obviously, yeah, as usual, just let me know what you think. Cold in Denmark, is it? How cold? How cold is it cold? How cold is cold? Because for me, -1 is cold. Oh, okay. Yeah, -6 is cold. I'll give that to you. Yeah, we're not -6, I think, at the moment. We're like -1 or something, -2. But yeah, okay, so let's have a look at this. Yeah, Edinburgh's always gonna be cold. Yeah, it's true. I don't know how you guys do it. I just don't, I don't know. I want to move something hot one day. I don't know if that's going to happen though. All right, let's have a look. So let's have a look at mandible. So it looks like -4 in Leeds. What's going on in this country? Are those normal figures to get? So is this a sort of Arctic thing that's happening right now? Okay, so let's go for, yeah, so someone's come out with it. So again, you know what? I'm going to try and show you guys. So let's do oblique, mystique oblique, whatever that's called. Let's MIP a bit and let's window a bit to try and make it look more like skull. Let's see what's going on. So, and then what we'll do, we'll just try and line things up a bit. So I genuinely think this is a really good way to spot fractures. And look, can you see? It looks like, I'm like Macbeth. I'm holding that skull in my hand. And can you see that straight away? Yeah, there is this linear abnormality located there, right in that sort of middle aspect of the mandible, right? So then you think to yourself, okay, well, that's one fracture, but you have to remember that a mandible is a bit like a polo ring. So if you're going to have a fracture, you're going to get a fracture in two places, not one place. So then you've got to start looking for a second fracture. Where could the second fracture be? So I haven't seen a second fracture on this view. So we may need to go here, maybe window a little bit more. Have a look. Can you see that? Just there. The fracture going down that way, down that way, down that way. I don't know if anyone's convinced by my method of doing it, but I definitely find it very useful. But look, the other side, no fracture. Come back to this side, there's definitely fracture. And if we just reset everything the way it is, meningioma, let's have a look actually. You see that? Meningioma frontal lobe. Someone feels as though they saw a meningioma. This one here. Yes, it could be. It could be. So yeah, you could get a calcified meningioma, very commonplace. It does look like it's extra axial, and there's probably going to be a bit of CSF space between this and that, so it's more likely to be one. Would I be worried about it? Not really. It's probably not causing enough mass effect to be causing any major issues. And yeah, I think the main problem with this person is that they've got these mandibular fractures. And if we look on this view, you can see it there. And then if we go NPR and go sagittal, you'll be able to see it coming up there. So quite a significant fracture going all the way along there. So this person was punched, right? So then let's have a look. So they were axial. Then looks like they got punched on the right side. Where was that fracture on the? No, it's left. Yeah. So you know that common thing that they say, like if you're gonna sustain injury getting punches, usually with the left side, because the person punching you is going to be. Oh yeah, you know the 3D. So I'll come back to the 3D recon thing because I've done exactly the same thing. So yeah, normally it's going to be the left side of the face that get injured because most people are going to punch you are going to be right-handed. Yeah, so the 3D reconstruction, you are right, but I have found on the occasion you do miss subtle ones because it does this tendency of like slightly smoothing over. So if it's like a really small fracture, it does slightly smooth it over, and it does a weird coloration thing where, well, the ones I've done, and you may want to correct me, but the 3D reconstructions that I've seen, they kind of make it look as weird creamy color, and it's actually just easier to have a black and white. And I found that over the years that doing that MIP method has been a really good way to make sure that I don't miss the fractures too much. Right, cool. But anyway, yeah, if it works for you, it works for you. Just a different method, and sometimes it may be worth trying all and seeing what works. Right, so let's have a look at this one. So this looks like it's a non-contrast CT. Thankfully, it's loading up. I know it's non-contrast because you can't see much in the way of what the kidneys look like. They look like I've got a piercing. So, I mean, I'm going to make a fair assumption that they must be young. Um, is that, I don't, maybe that's not a fair assumption. Apologies if it's not. Right. So now what we're going to do is, so this is, looks like a non-contrast study. We can see there's no contrast here. Let's scroll all the way down to the very, very bottom. Nothing going on there. We can see they've got an IUD in situ. Doesn't look like there's much in the way of inflammation. They've got abdominal pain. So what I usually do is try and go by a very systematic method. So let's look at the gallbladder. Gallbladder looks okay. Let's look at the pancreas. Not like the last one. This pancreas looks very, very smooth. It looks quite well defined. So that looks okay. Adrenals look okay. Spleen looks okay. Let's have a look at the bowels. So we'll quickly go through the bowels. Can be difficult. Scrolling this way, this way. Where does it go? Looks like it does a bit of a twist here, twist here, maybe. Then all the way up. The bowel up there, up there. We're up to the splenic flexure. Yeah, splenic flexure. Yeah, loads of answers coming through. Good. Transverse colon, hepatic flexure all the way down. Let's see if we can find the appendix. I always try and make sure that in every case I can identify the appendix. And I reckon it's be quite difficult on this one. Be very, very tough. But I reckon that thing there, can you see that? Might be the appendix. Very, very thin, tubular thing. Can you see that? So I reckon that's the appendix, and that looks normal as well. So then, yeah, people have done it. Yeah, so let's look at that kidney there. That kidney looks okay. Not much going on. This kidney, though, let's have a look. There is a calcification located in there, or calculus. There's two. One, two. Now we're going to have to make sure there's no obstruction. That ureter looks okay, doesn't it? Let's follow that ureter down. Can be a bit difficult. It's going to be one of these. Coming down, coming down, coming down. I feel like I've lost it, but it would be somewhere around here. I feel like I've lost it. Let's go from the bottom if possible. So that's going to be the vesicular junction. Coming up this way, I think it'd be in this area over here, isn't it? Coming up, but I haven't seen a calcification. It'd be anterior to the psoas muscles. No calcifications there, so it's probably not going to be. So either it's going to be a recently passed calculus, but I don't see any hydronephrosis or anything like that, or hydroureter. But what you do have is this fat stranding. For those that can't see it, if you zoom into that fat there, compared to that fat there in the subcutaneous tissues, this looks a bit kind of cloudy. So therefore, you probably want to go along the lines of this likely to be a pyelonephritis, younger patient more likely to be as well. Yes, it could be recently past calculus. Look at the white cell count, look at the CRP, look at the urine dip, see if there's any blood in the urine, and that may help you try and identify what it is. But yeah, this is I think I went with pyelonephritis on this one based on the clinical history and the white cells being up. Right, so let's have a look at this case. I think this will be quite straightforward on this one, if I remember correctly. So let's download. And this person hurt their hand, and let's have a look. So I know, I bet you don't believe me, but I genuinely draw around every single bone, everything, at least my eyes. But because we're here, I'll do it with the pointer. So that looks okay. That looks okay. They look like a fairly youngest patient. These look okay. I draw around, decapitate, lunate, scaphoid, nothing there. These all look okay. Then I would genuinely draw around. I always pay very special attention to the fourth and fifth because that's often where you get fractures, especially the base. You've got to be very, very careful. I've definitely seen a few miss there. Can't really see anything. I mean, there's that linear thing there, but I don't think it's strong enough to say there's a fracture. The other telltale sign can be that you get soft tissue swelling within that sort of hand area. So if you've got soft tissue swelling like this and it kind of sticks out like that, then you are okay, they've clearly got something going on. So you start taking a closer look. I don't think we've got anything like that going on here at all. We'll keep drawing around, nothing there. Draw around, draw around, draw around, nothing. All these look okay. Yeah, someone's got it, well done. Yeah, terminal tufts are very, very important. Number of times terminal tufts have been missed. So just have a look. Sometimes people have crush injuries, soft tissue injuries. And I always tell people as well, just be careful with calling fractures of the terminal tufts as well, because if you see a radiolucency, see if it lines up with the nail bed. If it goes like this, then you're not looking at a fracture. Look, it does this. Sorry, I messed that up. Close that. If it does this, then it's not a fracture. But this is all looking okay, all looking okay. And then, yeah, so if we draw along here like this looks okay, doesn't it? And then we come across this way, this looks all right. But this is where it looks abnormal, doesn't it? Like this. And then it's kind of got this zigzaggy edge there, a bit of a zigzaggy edge there. But it doesn't look like, when you get fractures and they're really new, it'd be like a very well-defined, very obvious linear abnormality. So you have to wonder whether this is kind of slightly older fracture. So let's see if this is an older one. Let's see, let's zoom in. So yeah, it still looked quite, very fairly well put together. So this could be an older fracture, but in the context of injury, this could be the primary fracture. The only reason why I say it could be older as well is remember I was talking about soft tissue swelling. There's not much in the way of soft tissue swelling, and you'd expect like if someone's really cracked their thumb like that, they would have had a lot of soft tissue swelling. So they probably have a fracture, but I think we're seeing it a little bit later on than like in the acute phase. The acute phase would have this fracture and a lot of soft tissue swelling, but we don't have that. But we do have what looks like a fracture through the base of the terminal tuft of the thumb that has some articular surface involvement as well. Right, let's have a look at this case. So I think there's a poll on this one. So if you feel like it, you can definitely take part. So let's have a look. You know what? I spelled, it's my dyslexia coming in, isn't it? So I spelled rib fractures wrong. Apologies in advance. So what can cause pleural plaques is my question because there are multiple pleural plaques in this. Let's have a look. So this is a non-contrast CT scan, and I guess they're trying to look for any long-term changes. So what we'll do, we'll have a look at the X-ray first. And I remember when I first started radiology, or even when I was a junior doctor on the ward, this used to scare me. Oh my God, they've got cancer. But that's not generally the case. If it looks like this, and they actually say they look like holly leaves, I think that's the way they describe it, like these kind of zigzaggy leaves all over the chest. And sometimes you see them kind of curve round the side, and that's because they're pleurally based. So things that curve round are going to be pleurally based lesions. And so these are multiple what looks like calcified densities, and you can see, they're calcified because they kind of almost look like the ribs in terms of its density. So these are calcifications, and some of them do feel like they're kind of going round the chest, round the chest, round the chest over here. And then the lungs actually look pretty clear, but I would be a bit concerned that there could be maybe some consolidative changes there depending on the clinical history. Now, my scan hasn't quite uploaded fully, so let me just reset all. Let's go to long windows. Let's have a look. So, as you scroll through, again, they've had a fair bit of breathing artifact. What have they said? Yeah, yeah, of course. Yeah. I know. I didn't put asbestosis as a choice just to but oh yeah, so the reason why I didn't put asbestosis as a choice because I thought it was fairly easy. That would be the primary cause for this, undoubtedly. There are multiple reasons for pleural calcifications. It can be infection. It could be like a pleurodesis because someone's trying to reduce the chance of having pleural effusions. Rib fractures can cause it because what ends up happening is if you have a rib fracture and the lungs are sort of breathing away and they keep rubbing against each other, then that can end up having like a what looks like a pleural plaque. So I just tried to throw something that maybe some people wouldn't expect, but you're right. In this particular situation, it's going to be most likely to be secondary to asbestosis exposure. You would worry about mesothelioma in a patient with asbestos exposure. The reason why it's not mesothelioma in this particular case, it's not a circumferential pleural thickening. So this is the pleura here, and you'd be looking at pleural thickening, circumferential pleural thickening, particularly of the mediastinum in a mesothelioma, along with the multiple pleural plaques. You do have multiple calcifications everywhere. They have breathed a lot, so it can be a bit difficult to really appreciate what's happened, but you can get a bit of fibrosis as a result of the previous asbestos exposure. And then we were concerned as there could be some consolidative changes located within the right lower lobe. And I think there could be. Can you see there? It just starts to look a little bit more hazy, a little bit more well-defined around that pleural plaque. There could be. Well, the reason I put it up was just to show you what pleural plaques, and like I said, there are varying ability that come to this these talks, and yeah, fair enough, maybe simple. Let's go to the very top of this one as well. Make sure we don't miss a renal cancer because that almost happened. And yeah, these look like very well-defined renal cysts. The upper abdomen looks completely normal. So yeah, we could walk away saying this is not unlikely to be mesothelioma. There's a lot of breathing artifact and multiple pleural plaques, potentially some consolidation located within the right lung base. No other significant findings. Cool. So we are coming up to the last one, and oh yeah, so let's share results. So actually, lymphadenopathy. So lymphadenopathy wouldn't really cause pleural plaques. You get calcifications of the lymph nodes. Lymph nodes would normally be in the mediastinum for the hilar regions, right? They normally follow the vessels and stuff, so you probably wouldn't get that. Consolidation, I guess so, if you get a paranomic pleural effusion secondary to consolidation, but generally speaking, it wouldn't. Rib fractures, like I said, which I spelt wrong, normally it's that rubbing sensation that can cause rib fractures. So this case was donated, so I thought it was quite cool. Um, let's go here. So this one is an X-ray of an ankle. And again, like I always say, always draw around, always draw around, always draw around. Let's make sure you draw around everything. Talar dome, you can often get osteochondral defects, normally in the supramedial aspect, because that's a lot where the weight bearing happens. I do look at the base of fifth to make sure there's no abnormalities there, and then look at the metatarsals as well. Everything looks okay here, but when you come up to the distal fibula, you see that kind of haziness there? Let's zoom in. Can you see that haziness? Look, it looks very, very well defined, very well defined, very well defined. And then you got this haziness there, and then you got like a normal, well defined. So when you kind of got that haziness, then you got to go with this possibly being, yeah, sort of a healing process. And because it's not like a clear sort of like fracture, you got to start worrying that this could be an underlying stress fracture. And that's actually where the MRI scan can be quite useful. I thought I did have an MRI scan. Maybe I don't. I thought I did. Oh, here we go. So let's have a look. So these are the fluid sensitive sequences. And let's go from the top. So you can see there's lots of edema. So this is fluid. Yeah, so it's going to be bright. And there's lots of edema within the bone marrow. But can you see that sort of thickening around it, almost circumferential thickening? That's the extracortication. And then why does that keep coming up? And then keep coming down. And then you can't really see any linear fractures per se. I'm going to just move that out of the way now. And then the rest of it looks okay. So then if we go to the T1 weighted images, I think T1 is actually really good for these. And potentially if we get a coronal, yeah, there we go. Let's have a look. It's around here. That's where all the action's happening around there, doesn't it? So let's have a look at coronal here. Let's see. There you go. Can you see that? So when you got this sort of ill-defined, well, on an X-ray, if you can't see a potential fracture, but you get that sort of fuzziness on any sort of long bone, then you've got to go for where this could be stress fracture. And with this one in particular, because it's not a well-defined, looks slightly hazy, there's a lot of sort of peripheral edema around it. Again, you'd be going down along the lines of this being a stress fracture. And that's actually fairly common to get stress fractures there, but you can get stress fractures in your toes as well. Question come up. You sound British. Have you sat FRCR2A? And if so, any tips? Okay, I'll do that at the end. Fine. So yeah, so I think we have gone through all the cases. So I'm happy to take any questions. And as always, I really do appreciate so many people turning up live and all the people that do sign up and watch us later on YouTube and interact with me on Twitter and all that kind of thing. I'm very passionate about teaching, so do give feedback. I think Becky's going to put a feedback thing on there for us. I will be back hopefully next month. Like I said, my daughter's not particularly well, so I would appreciate any prayers and positive thoughts and that kind of thing for her if possible. Someone has asked something quite specific, so I'm going to answer that. I sound British. Yeah, that's true. I am from the UK, but family from Bangladesh. I have set the FRCR 2A. The big trick is to try and do lots of past paper questions because most of the time, what you find is that people will sit exams, and if they fail the exams, they assume they're a bad radiologist. But in reality, failing exams have got nothing to do with how good of a radiologist you are, because you'll see bad radiologists get through the exams. Because if you want to see whether someone's a good radiologist, you look at the work that they do. You look at how they get along with their work. Are they making misses at work and stuff like that? But with 2As, the very sort of focal questions about very minutiae. So all you have to do is focus on that. It's not about radiology per se, it's about playing the game. So there is a book by a guy called Prometheus Linehart, which I think he opened my mind to that idea that it's all a bit of a game. And in the back in particular, he's got this thing where it's like, if this, then that. So the point is that if they use this phrase, then it has to be this problem. If they use this phrase, then it has to be this problem. So try and do that. Try and get into the idea about looking for potential phrases that will make you think it's this, right? That's the key. It's not about being good or bad. It's just about being able to answer questions in a particular format. So best of luck with that. And yeah, you're welcome. And I guess I'll see you on the next thing. And I'll hand over back to Becky. Thank you, everyone, and have a great evening. Bye.
Thanks, Imran. Yeah, thanks for another great webinar, and thank you to everyone that's attended. So yeah, you might have seen I've posted a link in the chat which has which will take you to our feedback form. Once you've completed that, we'll send out your CPD certificates. We really appreciate all of your feedback and input to make these webinars happen. And once again, thank you for attending, and hopefully we'll see you again next month. And I hope you all have a good evening or daytime wherever you're based. Thank you.